Assalamu alaikum. So today I'm going to discuss a case of a rheumatogenic retinal detachment that I did. So I angled the cannula at 30 degrees, pass it at an angle of 30 degrees up to the end of the cannula and then turn it vertically perpendicular to the eye. And so as you can see, I'm going to do a combined procedure. First I'm going to do the phacoemulsification of this cataractus lens, and I've passed to two cannulas. Now I'm proceeding to do the rexes. The rexes should ideally overlap the optic of the lens by 360 degrees, and this is important because it prevents posterior capsular opacification. And here at this point, the rexus tends to run to the periphery, and I pull it in using a centripetal force, and unfortunately superiorly the rexus is a little larger than I would have wanted. And here, as you can see, the detachment at the nasal and temporal area, then the at some points the vitreous is firmly adherent to the retina, and now I have to carefully release the attachment of the vitreous to the retina. So I do a co-vitrectomy, and then I stain the vitreous with triamcinolone, and here I'm trying to hold the PVD with the vitreous cutter and trying to release it from the vitreous from its attachments. And as you can see, at some points the vitreous is quite firmly adherent, so I have to debulk and slightly trim it. And here I try to remove the vitreous, and here from the detached retina it's proving to be a little bit challenging. I have to be careful that I do not tear the retina. So I at the points where it is very firmly adherent, I trim it and proceed again. And at this point, as you can see, I'm trying to detach the retina from the other side, from the other part of the detachment, and here I'm partially successful, but the retina is firmly adherent at some points, so I have to carefully trim the vitreous, and here I'm trimming the vitreous because it's proving very difficult to remove the vitreous from the retina. So at very low, by using foot pedal modulation here, I'm able to detach at one point, but unfortunately there is a break in the superior part, which I will note later on. In the superior part there is a small break after when I remove the vitreous, because at that point it was very adherent, so I mark it using cautery. And cautery I mark the break so that after fluid air exchange I'm able to identify where I have to do the I make a supranasal I decided to make a supranasal retinotomy, so I do endocautery in the supranasal quadrant of the retina. I did not inject the IL previously, so now I'm injecting the IL into the eye, and now I will be able to see how much the rexis overlaps the optic of the lens. Ideally it should overlap by 1 millimeter, and here, so it is overlapping but not in the superior part, and so I have to do better next time. So now I switch to fluid air exchange, and it is very satisfying to see the retina flatten at this point of the surgery, and it brings a sense of achievement. And I have to be careful because this is not a silicone tipped flute needle. And the I will use a silicone tipped back flush later, so that I can here I am using a silicone tipped back flush, so that I can come very close to the retina without touching it or damaging the retina or causing a bleed from the choroidal vessels. And now I have successfully flattened the retina. Jazakallah. Thank you so much for watching. Please give comments and suggestions. Jazakallah.